Good evening, all the aspirants present here. So, today the topic is molecular medicine, and the faculty that we have here today is Dr. Varun Pushkarna, sir. He is a senior consultant in internal medicine, Fortis Escortis Hospital, Amritsar. Sir, you may continue. Thank you.
Yeah, thank you. Thank you, Sana. Good
And
evening, everyone.
And also, for the aspirants, I want to say if any question or queries you have regarding the classes or any question, any topic, you can unmute your mic and you can ask here. Thank you.
Yeah, thank you, Sana. Good evening and welcome all the aspirants. Basically, today's class is of a very, important but a small topic. So, molecular medicine.
এক্সরে গুলো ভালো থাকলে ঠিকই আছে।
Yeah, can you please mute your mic? Okay. So molecular medicine, many times, when I was a student, I had a hard time finding out the topics on which molecular medicine is based. So basically, molecular medicine, it goes back to these topics of genetic basis of disease, some diagnostic tests which are, coming up in a good manner now, and they basically are required for establishing diagnosis of several conditions like PCR, like we did in COVID also, RT-PCR was done. So it is a molecular diagnostic test. Then comes gene therapy. Nowadays, the focus is on altering the genome of humans to treat certain conditions like cystic fibrosis and other conditions, which can be corrected through genetic therapy. Then pharmacogenomics, molecular oncology. Uh, these days, whenever we are talking about somebody having a cancer, they are always talking about some chemotherapeutic agents and then immunological drugs, and then they are talking of some newer drugs which are actually affecting at the level of the genetics. So oncogenetics, that is known as, then epigenetics, and then this new procedure known as CRISPR and genome editing. We'll discuss about it. It is an important upcoming topic, and uh, very soon we will have a lot of questions coming from CRISPR and genome editing, and then the mitochondrial genetics also. So basically, genetic basis of disease is very important. We all understand there are certain diseases which are connected to the genetics, and certain diseases which can be inherited. Some are because of de novo new mutations. In some conditions, the mutations they travel down the family, and then these mutations they continue to amplify themselves, become bigger and bigger until and ultimately when one family member he dies, and then the legacy stops. So we have to understand that all of these inheritances, these genetic depend base of the disease is very important, because not all people who have similar genetics they develop similar disease profiles, because there is some environmental contribution also to the disease. So genetic basis of disease may be with understood with Mendelian inheritance, like we've been studying since plus one, and they are autosomal dominant, autosomal recessive, X-linked disorders. These Mendelian inheritance mean they divide the chromosomes into two types. One is the regular chromosomes, and then there are sex chromosomes. So whatever is inherited through the regular chromosomes, they are known as autosomal diseases, where just one gene is important, as one chromosome is important to carry the disease. It is called autosomal dominant, where two copies are required. It is autosomal recessive. And when a disease is transmitted via the X-linked pathway, that is through the maternal genes, because XX is female and XY is the male. So every male has an X coming from their mother, because father only contributes Y. So whatever diseases are there, the X-linked ones, they travel through the maternal pathway. So mothers give it to their sons, and mothers give it to their daughters, and the daughters are usually carriers, and sons are usually the disease manifestors. So these are the X-linked disorders. Then comes the chromosomes when they are deficient or excess by themselves. For example, human beings, they basically, we have this 46 and 2X chromosomes or 2XY chromosomes. So whenever the 13th chromosome becomes three times, the 21 chromosome becomes three times, for example, that is Down syndrome. Oh, my pen. Yeah, that is Down syndrome. So Down syndrome is trisomy of 21. Then Turner syndrome is when 45 and XO is there. So it's not even 46 chromosomes, it's 44 plus two chromosomes X, and either it should have been X. But because there is no Y in it, the genotype is 45XO and the phenotype is that of a female. Then Philadelphia chromosome is the translocation from ninth chromosome to 22nd chromosome, and it carries a very potent kind of a combination to yield a disease known as CML, which is chronic myeloid leukemia. Then there are mutations which can affect the human, genome, leading to disease onset. For example, sickle cell anemia, where the it is replaced by valine and beta globin gene. Then there is a frame shift mutation. Frame shift mutation usually seen in cystic fibrosis, where it is the F508 delta mutation. So these frame shift mutation leads to cystic fibrosis. CFTR gene is the defective component. The chloride balance is distorted, and all the secretions, they become so thick that they find it difficult to flow, and hence leading to choking of the airways or the any tubular system of the body. Then there are very important diseases which are known as trinucleotide repeat. We all understand DNA. There are nucleotides which have to be in a different setup. But then when a triplet continues to repeat itself, like GAG repeat, then it is Huntington disease, Friedreich's ataxia, so on and so forth. These diseases, they are very important, and they have the genetic basis of disease. Clinical relevance is that we need to understand these mutations, because if you can find these mutations via the diagnostic tests that we will be reading just now, then you can diagnose the hereditary diseases, and you can apprise the family that as to continuing their marital life and producing children, or take a different course of action. Predicting the prognosis and tailoring treatments, like nowadays we have CFTR modulators available for cystic fibrosis. They are available only if the diagnosis is confirmed by genetic testing. Then comes molecular diagnostics. For example, polymerase chain reaction, PCR. PCR nowadays is done for so many diseases like HLA-B27 is done by PCR. COVID-19, COVID-2, we would do a PCR. So many PCR, HIV PCR. PCR is done a lot these days to detect the diagnosis of infectious diseases, or sometimes even the mutations. We try to replicate these mutations more and more so that they become evident clearly under the microscope. Then fish is fluorescence in situ hybridization. So basically we have a defective chromosome. All we do is just try to hybridize it with normal chromosome and make it multiply. So when they are tagged with a fluorescent marker, so when they replicate, they multiply. So what you see is more copies of these fluorescent targeted tagged genes and their chromosomes that you can see in CML. Then nowadays is available next generation sequencing. So these are done in like spinocerebellar ataxia. Unless you sequence these genes, you are not able to diagnose. So high throughput sequencing, or for cancer genomics and rare diseases like spinocerebellar ataxia, these are only diagnosed these days via next generation gene sequencing. So molecular diagnostics, they provide rapid, accurate. I mean, you can have diagnosis within 7 days. So accurate diagnosis essential for personalized medicine. This is something else. Like these are rare patients, like spinocerebellar ataxia is of so many types, and in some types there is treatment available. So not everybody can be given the same treatment. So the personalized medicine, such as identifying actionable mutations in cancers for targeted therapies. Okay. Then comes gene therapy. So this was basically theoretical. Now it is basically being utilized. So in treatment, for example, we see that somebody has a gene which is M7. So what we do is we take a virus and we put that gene into that virus's chromosome, and then we let it infect us. So once we are infected, that chromosome is, or that gene is integrated into the human DNA, and then the gene that was deficient in that human, it will be replenished. So that is basically introducing a functional gene to replace a defective gene. For example, ADA gene in SCID. SCID is uh, basically severe combined immunodeficiency syndrome. Then gene editing, CRISPR-Cas9 technology. You can actually cut and remove the defective gene from the genome. Again, that is used to be a theoretical thing. Now it is practically done, and then using viruses to deliver the therapeutic genes. For example, very not very remotely, we will see that viruses are being used to treat cancers, because in cancers we know that multiplying genes, the telomerase is defective. So if the adenovirus or any lentivirus which is used to carry those genes and implant it there, then the replication of the cancer will stop. So the cancer will be there and it will be rendered benign because it cannot multiply. And cancer by definition is unabated multiplication of the uh, cancer cells. So clinical applications, now that approved therapy is there, which is called Luxturna. This is for inherited retinal dystrophy, and gene therapy trials are being conducted for hemophilia and muscular dystrophy worldwide. So these are the gene therapy targets which will be followed in times to come and will be asked in the exams.
And I have to make an announcement that, as many know, that we are having a 3-day PACES course in KPC Medical College, right, where all the MRCP faculties will be present with us. Varun Pushkarna sir will also be there. So I'll send the flyer in the groups. Please circulate it with your friends and colleagues. If anyone need us, we'll be there to help. Thank you.
Thank you, Sana. Thank you, participants. Take care. Have a nice weekend.